So we are live. We're just gonna wait for a few minutes for people to join.
Okay.
Uh, are you excited to be here?
Very excited. Very excited.
Awesome, awesome, awesome. So we'll wait for a few minutes and see. Oh, someone is iffy. Iffy Lola. I hope you can hear us. We can't hear you. Let me see. Where is she? I'm seeing another. Oh, awesome. All right. Yeah. So the last time, you know, the last time I tried, I wanted to like figure out how to play music, start music and stuff, and I never did. And now I'm back here again, thinking I should have probably figured that out. Now we could have. No, I think yes. Now I think we can. Let's see. Let's see. Nice. Okay, so Nito, I'll have you like okay, let me just welcome everyone to the live. We are ready, we are starting today. We are going to be talking about diabetes. If you found me on Facebook, as you come in, please let us know where you are watching from. Leave a comment, let us know. Let's be um active in the chat. We're gonna have fun in the process of learning. So I'll give it up to you, Nito, to like tell everybody like your journey, your name, what you do, how did you get to where you are right now?
All right. So my name is Netochi. Everyone calls me Neto for short. Born in Nigeria, and came over to the United States for college. And
Uh,
I
mhm.
am where I am today because of one, my sister,
Oh,
because she
okay.
pushes me, motivates me to be a better person every day. So I won't be where I am today if not for her. My mom and my parents, and my brother, all my siblings, So I feel like that motivation, that push gets you to where you are. Um,
Absolutely.
and I currently am director of clinical pharmacy services at a federally qualified health center in Reno, Nevada. And with the program that we run, we help get diabetics under control. So my role, my job is so if a medical provider is having a difficult time with certain medications, insulin management, they get referred over to our program, and we help get those patients their diabetes under control, and then refer back to the referring provider. So yeah, I have a wife and two daughters,
Hmm.
and a dog named Melvin. And yeah, I'm very happy to, I'm honored to be here. Um, thank you, Indy, for giving me the opportunity to talk about something I like. Um, I became a pharmacist about 6 years ago,
Oh, wow.
and I was I wanted to learn more. Even once I was done with school, and I first pursued board certification in advanced diabetes management. Um, and then that was specifically for diabetes, but I wanted something broader. And then I pursued another board certification in ambulatory care pharmacy, which is pretty much like being a specialist in outpatient pharmacy.
Hmm.
So with those two board certifications, I feel like I'm able to serve our my patient population better. Just with some because I what I bring to the table is might be different from a traditional pharmacist. Just because I have some more focus in with some specific disease states, which mainly outpatient disease states. So yeah, so that's my day today. That's who I am, and
I mean, like, that's I think you should like really motivate young men, like young people, because where you are right now, it's not a lot of young, like a young guys that are where you are. So that's just amazing. That's
yeah, it
awesome.
is. And sometimes it gets very intimidating because sometimes at work, when we have like a senior leadership meeting, and there I am, and everyone else is in their 50s, and they're like, who is this? Who is this? you know young person in the room.
Young black, a young black guy.
Yeah, so it's very intimidating, but again, it's very motivational because it just makes me want to work harder and prove everyone wrong. So
Yep.
it's intimidating, but it's also very motivating, um to make me do better every day. Because if someone says you can't do something, it's always an awesome, and then it's like, okay, well, challenge accepted then.
Mm, I like that.
Yeah,
Wow,
yeah,
that's
so
great. Awesome. All
yeah.
right. So I have your slides. So if you want me to start sharing it, just let me know. But this is now yours.
Okay. Yeah, I'm ready when I'm ready when you are. Okay. So do I have control over the slides, or do I just
No,
let
so
you?
you just tell me when you want me to move, and I'll just move to the next slide.
Okay. All right. So yeah, so today's talk is going to be on pharmacological therapies for diabetes. Um and like I said, my name is Netochi, but everyone calls me Nato. Please feel free to ask questions, post in the chat if you have any questions. From my understanding, it's a mix of healthcare professionals and non-healthcare professionals. So please, um, if you have any questions, please let me know. Um, all right, so where I work is called Community Health Alliance. Like I said, we're a federally qualified health center located in Reno, Nevada. We have seven different medical groups around the Reno area. We have two in-house pharmacies. We're currently working on making a third pharmacy at one of our other locations. And we have around 30,000 patient population, around 250 employees. We keep growing. And the mission of our organization is to provide quality healthcare to everyone, regardless of ability to pay. So within our clinic, we have clinical pharmacy, we have retail pharmacy services, we have dental, behavioral health, women's health, WIC, and nutrition counseling.
Wow.
All right. So our objectives today, we're going to talk about statistics about diabetes. We're going to define what diabetes is. Going to talk about some risk factors, and we're going to dive into the individual therapies for diabetes. And we're gonna talk a lot about those that have cardiovascular benefit, because that is kind of where most guidelines are going towards, is putting people on medications that have been shown and proven to reduce risk of cardiovascular death, or heart attacks. And we're going to talk about some general pearls, and some recommendations I always give some of our medical providers when, if they're in any bind or challenge with the patient that has diabetes. And we're going to talk about some delays in prevention.
I'm ready
So,
to learn too.
so, so please, like I said, just let me know if just stop me, ask me questions at any time. I'll be very happy to to talk. I could talk about diabetes for hours. Uh, so please, if there's any, just if you want to, if there's anything you want to talk about more, I'll be very happy to keep going. So, all right. So the prevalence of type of diabetes in general. So in 2019, according to the CDC, and even as of today, 2022, they still refer back to the 2019 data because it takes time, for some of these statistics to be put together. But in 2019, about 37 million Americans have diabetes, which is about 11% of the population. Out of the 37 million, 28 million or 29 million have been diagnosed with diabetes. So they know they have diabetes. And out of that 37 million, about 9 million had no idea they had diabetes. And they randomly found out during like health fairs and things like that. So among seniors over 65, about 16 million seniors have diabetes, and pre-diabetes 96 million Americans. So some of these numbers are staggering. 11% of the population. That is a lot of people who have diabetes. And this is just going to keep growing every year.
Wow, that's a lot.
Next slide, please. All right. So as far as breaking it down by race, according to the CDC, so about 15% of American Indians have diabetes in general. Non-Hispanic blacks or African Americans or Africans, about 12%. 11% for Hispanics, around 10% for Asian Americans, and non-Hispanic whites, about 8% or 7.4%. All right. So as far as new cases, new onset or newly diagnosed diabetes, about 1.4 million Americans are diagnosed with diabetes every year. I always look at this number and it blows my mind because that is a lot of
That's
people.
a lot.
Every year, I'm getting diagnosed with diabetes. And again, like I said, this number just keeps growing. All right. So as far as death, diabetes was the eighth leading cause of death in the United States. And the top three are one, heart disease. Your first is heart disease. Number two is cancer. And recently now COVID is in there. That's number three cause of death. So prior to COVID, diabetes was number seven, but COVID kind of bumped diabetes down. But as far as kidney disease, lower limb amputation, and blindness, diabetes is the number one cause of these in the United States.
I'm so glad that you added this because I think one of the main issues, one of the things that I've seen is people not realizing how diabetes can get worse. Like
Mm-hmm.
it can kill you.
Mm-hmm.
And sometimes when you tell people like diabetes can kill you, they look a little bit shocked. Like,
Mm-hmm.
you know, they have diabetes, but they don't take it seriously because some of
Exactly.
them they are not having the physical symptoms.
Exactly.
So
Exactly.
they think that they can just
Yeah. Yeah.
eat whatever
And
they want.
yeah, and even just looking at this number too, I mean, when you have diabetes, you're at 3 to 5 times higher risk of having cardiovascular disease. So, I mean, even if heart disease is number one and diabetes is so when I dove into like the CDC's explanation of this, and pretty much this is when they look at a death certificate and they say died by the cause of death was diabetes, but having diabetes by itself puts you at a higher risk of having cardiovascular disease. So cardiovascular or heart disease being number one there's probably a lot of contribution from diabetes that led to that heart disease, that caused that death. So even if it's number eight here, I would say it's a lot higher than number eight. But just based off the actual not physical count, when they look at death certificates, it ends up being number eight. But I definitely feel like it's up there because of how much it contributes to heart disease.
Mm.
All right. So what is diabetes? So diabetes can happen when your body has decreased insulin production, increased insulin resistance. So when your body is not using its insulin like it should, or when your body is destroying the cells that produce insulin. And these ultimately all lead to increased blood sugars in your bloodstream. So, okay. Next slide, please. All right. So I have a little pictorial here that gives a pretty good explanation or a general summary of diabetes. So typically, when you eat foods rich in carbohydrates or glucose sugars, that glucose goes into your bloodstream, and you can see the two pink balls. Those are like let's say your glucose there's a glucose in your bloodstream. And then insulin there, the triangle, when it binds to your receptor in your cell, it opens up a door. So insulin opens up the door that allows the glucose in the bloodstream to go into your cells, so your body could use for energy, or your body could store it for energy later. So if for some reason you don't have all of that insulin on board, or your body is not using that insulin like it should, the green triangle there, that glucose is not going to go through those doors into your cell for energy. So the glucose just stays around in the bloodstream and increases your blood sugar. So earlier when we were talking about the diagnosis or the definition of diabetes, it's one, reduced insulin production, so your body's not producing insulin, so that sugar stays around, or two, insulin resistance, so your body that insulin is not being utilized like the way it should, and all that glucose stays in the blood, or your body is actually destroying that insulin. So all of those will lead to the increased glucose in the bloodstream.
Mhm.
Next slide. All right. So as far as risk factors, so some general risk factors for having diabetes, it could be genetic. You have a family history of diabetes, um, um, physical inactivity, if you're obese, if you're a smoker, if you have unhealthy diet for a very long time, and and people who live in larger cities or big cities, just because there is a lot of that physical inactivity in those big major cities. Most people don't do a lot of physical activity. You don't go, a lot of people don't go running. They stay home. They don't go to the gym. So it's studies actually show that 65% of people who live in major cities have type 2 diabetes. Okay, next slide, please. All right. So some symptoms of hyperglycemia, and hyperglycemia simply means high blood glucose. So increased hunger, because your body needs some of that glucose for energy. So your body tells you to go eat some more food. So
Mhm.
increased hunger, increased urination, because your body is trying to pee out some of that excess blood sugar. Extreme fatigue, non-healing wounds, impaired vision, increased thirst, unintended weight loss,
Mm.
and urinary and genital infections. And I want to talk about the unintended weight loss there, because some people don't really understand, that. You hear people say, I have diabetes, but I've been losing weight, and I'm not really trying to lose weight, but I'm losing weight. It's a good thing. And we're like, oh no, that is not a good thing, because if you're having unintended weight loss when your blood sugars are high, that means your body is starting to get to a point where you're not producing insulin anymore, and your body is starting to break down that fat. Your body's looking for other sources of energy, and you're starting to break down fat for energy. So that is not a good sign if you're having
Mhm.
unintended weight loss and you have diabetes. Okay. Next slide, please. All right. So, diagnostic tests for diabetes. So, this is some tests that your doctor might do, or you might order for a patient that has diabetes. So, blood glucose, something called a hemoglobin A1C, which we're just gonna call it A1C from here on. And what that is it just measures how much glucose is on your red blood cells. So it's a test that your doctor will order every 3 months, or sometimes sooner or sometimes later, to see how much sugar is on your red blood cell, to kind of give a 3 month snapshot or a 3 month average of your sugars, and and antibodies. So depending if you're trying to specify or know what kind of diabetes someone has, you might need to order some antibodies, and those are some common antibodies that might be ordered. And there's a test called a C-peptide. C-peptide measures how much insulin your body is naturally producing. So C-peptide normally is released when your body releases insulin. It comes as a pair, and it's an average or a good estimate of how much insulin your body is producing by measuring the C-peptide.
So I recently had to dealt with this for the first time. So I had a young guy that just happened to I got involved with, and I was trying to figure out if this person had type 1 or type 2 diabetes. Can you talk a little bit about that? Because that's I know these are the tests that I ordered to kind of differentiate. Can you
Mhm.
like tell people how the difference between one and two?
Absolutely. And I have a slide that goes over that. So I want to say that might be the next slide. But,
Okay,
but yep,
sure.
that's
Okay,
I'm
great.
definitely I have that on there. Okay,
Oh
so
yes.
all right. So So as far as a diagnosis for diabetes, so remember we talked about an A1C, which is how much sugars are on your red blood cell. So that A1C, if it's a test done and it's measured by a percentage, so if your A1C is above 6%, it could be a diagnosis. It could be a diagnostic test for diabetes, or your fasting blood sugar. True fasting sugar is when you haven't eaten for 8 hours and you test the blood sugar. So that should be, if it's above 126, could be a diagnosis of diabetes. Or a glucose tolerance test. That's when your doctor might give you like 75 grams of glucose and they test your sugar again in about 2 hours. And normally your body should bring that sugar down naturally. But if that sugar is too high at 200, it could be a sign of diabetes. So typically it's two of these positive tests. So either a glucose, fasting glucose, and an A1C, but two of the three need to be positive before you get that diagnosis of diabetes. If only one is positive, then your doctor might have you come back a little bit sooner to get another test. And then pre-diabetes is where you don't yet have that diagnosis of type 2 diabetes, but you're on that road. So those are the numbers there, and then those are your normal numbers. Okay. Next slide, please. All right, so what are your types of diabetes? So you have pre-diabetes, like we talked about in the previous slide. Type 2 diabetes, type 1 diabetes, and there's gestational diabetes, which we're not going to talk about today, but that is related to pregnancy. Okay. Next slide, please. All right, so what is the difference? So here's your answer. What's the difference between type 1 and type 2 diabetes? So type 1 diabetes, 5% of the population have type 1 diabetes. And this is absolute insulin deficiency caused by autoimmune beta cell destruction. So those antibodies that were in our previous slide, there's a GAD65, the insulin autoantibody, the islet cell antibody. So those are markers or signs that your body is naturally destroying the cells that produce insulin. So there's a very common test called a GAD65, which stands for it's I'm spacing the anyway. So it's called GAD65, and it's a breakdown of that beta cell. And so if your body is breaking down that cell that produces insulin, um, that GAD will be positive. And it's a sign that your body it's type 1 diabetes because it's an autoimmune cause of your diabetes. So it is quick and severe. A lot of times people who have type 1 diabetes are diagnosed in a hospital because they go to the hospital with extreme symptoms of usually diabetic ketoacidosis, and that's where they find out they have type 1 diabetes. And the GAD, yeah, so it's called glutamic acid decarboxylase is what it is. So it's a breakdown of your beta cell. All right, so it's primarily in the youth, so usually younger kids, but it can happen in some adults. Type 1 diabetes cannot be prevented because it's autoimmune and it's only treated by insulin. So the test, so when if you're trying to differentiate, with labs, a patient that has type 1 or type 2 diabetes, is, you order those tests. So you order the antibodies and you order a C-peptide. So the antibody test will tell you if the person has the antibodies that are destroying their natural insulin. And that C-peptide test will tell you how much insulin the person is producing. So typically the antibodies will be high and then the C-peptide levels will be low, meaning that, they are producing antibodies and their body is not producing insulin. I'll talk about this later also, but it's usually recommended if you're drawing those labs to have a patient be non-fasting because you want them to eat, because you want to see, because if they go do the test at fasting, your blood glucose are going to be low and there might not be a need for their body to produce insulin. So that C-peptide could be falsely low if they're fasting. But if they eat first and your glucose is high and they go do the test, then tentatively their C-peptide should be high because their body should be producing insulin. But if they go do the test and your glucose is 200, C-peptide is still low, that is a sign of a patient is not producing endogenous insulin. And you could use that to differentiate, type 1 or type 2 diabetes. And it could also help you tell if the patient needs to be on insulin or not. So does that answer your question, India? Does that kind of clarify?
Yep, absolutely. And I'm definitely watching this again later.
Okay. And for type 2 diabetes, it's 95% of the population, so almost the general bulk of diabetes. and that's mainly insulin resistance. So your body is not producing insulin like it should, or progressive insulin deficiency. So it's been happening for a very long time. So years and years, your body, has just been slowly reducing how much insulin is producing because of a history of unhealthy lifestyle. So your body has overworked with your high blood sugars and your bad diet, and all of a sudden your body is not producing insulin like it should over time, and your body does not use insulin like it should. So it's more of a slow, gradual process, years and years. People have no idea, until their doctor tells them you have diabetes, and then they're surprised. So primarily adults, but it seems like the age keeps coming down every year.
Mhm.
Now, you see a 12-year-old with type 2 diabetes or a 10-year-old with type 2 diabetes, whereas in the past, that was never the case.
Uh,
Type 2 diabetes can be prevented or delayed, and it's treated by both non-insulin medications and insulin medication. So you could use some medicines that are not insulin to treat type 2 diabetes, and you could use some insulin to treat type 2 diabetes. All right, so this slide right here, I'm not gonna talk too much about it, but it's called the Omniosectet, and it just shows that a lot of different parts of your body, different organs, play a role in increased blood sugar. And when we dive into the medications, I'll refer back to this slide to show where each medication works
mm.
in different parts of the body to help reduce your blood sugars. Next slide, please. All right, so now is kind of where we get into the things I really like. The medication. So I apologize if if I start going off um, on these, because this is my bread and butter. So I just included the major medications that are used in diabetes, and this is just a general slide to show the weight change, if there is cardiovascular benefit, if you can use them in heart failure, the cost, as far as renal impairment, what's safe and not safe in renal impairment, if it causes hypoglycemia, and percent of that A1C reduction. And we're going to go through each of these classes one by one. I'll try to go fast because I know we have about 30 minutes left.
No,
But
take your time.
okay. Well, please just stop me or ask me any questions as well. All right. So the biguanides, or metformin, it's also called glucovage or glumetza. So this is the gold standard for diabetes treatment. If you have diabetes, everyone starts on metformin.
Mhm.
So according to the guidelines, it's the preferred initial treatment for type 2 diabetes. So back to this omniosectet that we saw earlier. So metformin works in the muscles, and it works in the liver, and it also works in the stomach. So metformin helps reduce the excess production of glucose that your liver is producing. It also helps reduce the amount of glucose your stomach is absorbing when you eat foods rich in carbohydrates, and it helps improve insulin sensitivity. So it allows your body to use your insulin like it should better in the muscle. So that's the three main ways metformin works, and it reduces A1Cs roughly by about 1 to 2%. All right. So as far as dosing, typically, you start metformin at 500 milligrams once a day or twice a day. So there's a 500 milligram, or there's a 850 milligram once a day. And typically dose adjustments is you increase by 500 milligrams every week, because of side effects. A lot of people cannot tolerate metformin due to stomach side effects. It could cause bloating, gas, diarrhea. And typically a lot of people stop metformin because of that reason. But so you start slow, and then you slowly titrate up. And the maintenance dose is usually, everyone should be okay at 2,000 milligrams a day, so 1,000 milligrams twice a day. But you could go up to 2550, which is if you're using the 850 milligrams, you do that 3 times a day. But there is no difference in benefit between a 2,000 milligram a day or 2550 milligrams a day. So, okay. Next slide. All right. So, as far as dose adjustments, so if your kidneys are not working like it should, metformin will need to be dose adjusted um, to 500 milligrams twice a day. And you don't want to use metformin if your kidney function is GFR is less than 30. As far as side effects, like we said, diarrhea, nausea, vomiting, bloating, but it is self-limiting. So those side effects will get better. So I always let people know, if just give it about 2 weeks, it will get better. I know you might have those symptoms for right now, but those symptoms will improve. Um, So um, I usually recommend there's a metformin extended release form, which is slower release in the stomach. So that helps alleviate a lot of those stomach side effects. So at this point, I typically start everyone on metformin 500 ER just to reduce the complaints of the stomach side effects. And long-term use of metformin can reduce vitamin B12 levels. So some of those patients who might start having, neuropathy, tingling, you might think, are they having diabetic neuropathy? But if they've been on metformin for a long time, it might be time for you to draw a vitamin B12 level to see if it's the vitamin B12 that's low or is it truly diabetic neuropathy. Before starting to prescribe other medications for neuropathy, just check the vitamin B12 levels first to see if that's why. And metformin is very cheap. Cash price is around $4 a month.
And I know that they have metformin back home too. So I'm curious if anyone is watching from like Nigeria or Ghana, wherever you're watching from, like, does the doctor over there, if you know, like, do kidney function to check your kidneys if you're on metformin?
Absolutely. Okay, so next class is called your sodium glucose transporter 2 inhibitor. So for short, it's called SGLT2 inhibitors. And these are fairly newer medications, and there are four on the market right now. There's one called Farxiga, there's Invokana, there's Jardiance, and Steglatro. And those are your doses. I'm not going to go into all of this, but those are your dosing. And again, these will also need to be dose adjusted based on your kidney function. All right. So, I'm just going to call them SGLT2 inhibitors. So the SGLT2 inhibitors they primarily work in the kidneys, and they work independently of anything else. They work in the kidneys. So typically, what happens when you have diabetes is when your sugars start going up, your body tells your kidneys to get rid of that excess sugar. So you may end up peeing a lot. That's why one of the signs of diabetes is increased urination, because your body is trying to get rid of that excess glucose. So these medications, what they do is they reduce that threshold, I guess we can say. So let's say your body normally has you pee a lot when your sugar is 200, for example. What the SGLT2 inhibitors are doing brings that number down to like 140. So when your sugars are above 140, for example, you start peeing out more glucose and not having your sugars go up so high. So they reduce the way your body is retaining a lot of that glucose in the kidneys, and it makes you pee out. So it works independently of anything else. So if your sugars are high, you're going to pee out your glucose. That is primarily how these medications work. And their A1C reduction is roughly around 1%. All right. So these medications have been shown to reduce cardiovascular death and reduce cardiovascular disease or death in people who've already had. So, for example, let's say you've had a history of a heart attack in the past and you have diabetes. These medications have been shown to reduce your risks or chances of having another heart attack again. So it's a good medication to be on, or your doctor might put you on if you've had a history of cardiovascular disease. And the two on the market right now that have that data is for Invokana and Jardiance. And just because you might be also getting rid of some excess fluid, it can reduce blood pressure. It helps to reduce it is some weight loss, but the weight loss is debatable because we're not sure if it's because you're losing water or if it's actual weight loss, but it does reduce some weight. There's current data also to use these medications in people who have heart failure, even without diabetes, which I find very fascinating because these medications are primarily for diabetes. But now they're starting to show that even if you don't have diabetes, but you have heart failure, your doctor might put you on this just because of some additional benefits that this medication has. And it also reduces progression or worsening of diabetic kidney disease. So if you've had diabetes for a long time and your kidneys are not working like it should, these medications also help relieve some of that pressure on the kidneys and can also reduce how fast that your progression of diabetic kidney disease is going. So it might be a medication you might be on if you have heart failure, if you have kidney disease, and if you have diabetes. So it's they're starting to realize that these medications have a lot of benefits the longer people are on it. Excellent. All right, so how side effects go. Because you're going to be peeing out excess blood sugar, Bacteria like sugar. So if you have a lot of urine, glucose in your urine, it can increase your risk of having a urinary tract infection or genital yeast infections. So I always advise everyone to have appropriate genital hygiene and to stay well hydrated on these medications to reduce the risks or side effects of those genital yeast infections. So it makes you pee a lot. And there's something called euglycemic DKA that the studies have shown, which I'm not going to go into in depth. But if you have any questions, you can we could talk about it more. But it can cause what's called euglycemic DKA, where your sugars might be low or normal, and you might still have DKA just based off how it works. Um, Average cost, so they're still brand name, but they're still very expensive cash price. But a lot of
Mm,
insurances are covering them now because of the benefits. So if you have insurance, it might be covered, but out of pocket costs are they're pretty expensive medications still.
these meds are tough on people with no insurance.
They are. They are. Okay. All right. So the next class I'm going to talk about is they're called the glucagon-like peptide. For short, they're called GLP-1 receptors. These are also fairly new. You have Byetta, and these are most of these are injections. There's Byetta, there's Bidurion, there is Victoza. So there's a question in the chat asking if SGLT2 inhibitors can be monotherapy for diabetes or as an add-on to metformin. SGLT2 inhibitors, guidelines are starting to show it possibly can be used monotherapy. If you're starting, if someone is newly diagnosed, you start with metformin and then you can add on an SGLT2. But if someone comes to you and they have a history of cardiovascular disease, they've had a history of an MI in the past, or they have, diabetic kidney disease, their GFR or their kidney function is, less than 45, it might be time for you to add an SGLT2 inhibitor even before you add metformin because of the protective benefits. So it all depends on the stage the person is when you see him, depending, and that'll help you determine if you could possibly use an SGLT2 as monotherapy before metformin if a patient has some of those disease states that the SGLT2 inhibitors have been shown to reduce, cardiovascular mortality or reduce progression of kidney disease. All right, so the GLP-1 inhibitors. So Byetta, Bydureon, you have Victoza, you have Adeolokun. The two, that you might see on TV these days for commercials, you might see Trulicity on TV, you might see Ozempic on TV. Those are once a week injectables. And right now most people are on those because they're once weekly as compared to the
Mm-hmm.
top four. Because the top four are either once a day or even twice a day. Bydureon is also once weekly. But the two you see a lot are Trulicity and Ozempic. There's a question in the chat. Any advice for patients with GI intolerance to metformin and are unable to afford the other classes? So my first advice, will be try extended release metformin and always take metformin with food. Taking it with food to help relieve some of the GI upset. So I would just recommend, one starting at 500 milligrams once a day with the largest meal. Typically start with dinner. I always say start with dinner with largest meal just so you can sleep through some of those side effects. And then, after like a week of taking it once a day with dinner, then you could try breakfast and dinner once with food. If that's not working, then I just go to the extended release. But right now, most insurances cover 500 milligrams extended release just fine. If you're trying to do 1,000 milligram extended release, some insurances might not cover it, but 500 milligrams ER, most insurances are covering. So if you've tried that, and I usually just do the 500 ER once a day. And in all honesty, I mean, you don't have to get up to 2,000 milligrams of metformin. Any little bit of metformin helps. Even if they're doing 500 ER just once a day and that's what they could tolerate, that's fine. Because some of these medications are synergistic. So, it might not just be like an add-on, but there is, so even if they're just on 500 milligrams of metformin and an SGLT2 and GLP-1, they're all synergistic to help. So, yeah, with food and a try extended release. Okay, so Ribelsus, the last medication on that table right there, that's the first oral GLP-1. So the other GLP-1s are all injectables because of your stomach acid breaks it down. So the GLP-1 class is a natural hormone, almost like your insulin is. And your stomach acid degrades the medication. So in the past they weren't able to find an oral formulation, but Rybelsus is the first oral GLP-1. Is the same molecule as Ozempic, and it's a once a day compared to the others that are injectables. Okay. And these don't need to be dose adjusted in renal function just
Mhm.
because they're not cleared through the kidneys, but you just need to be cautious if a patient has kidney disease.
All
Okay.
right. So I think somebody asks, does is insomnia somehow connected to
Blood
blood
sugar.
sugar levels?
Yeah, yeah, absolutely. Different things can increase your blood sugar. So you have, something in your body called cortisol, and cortisol, it's kind of it helps wake you up in the morning. It helps you might have higher cortisol levels if you're having stress. And cortisol is like a steroid, and steroids can increase your blood sugar. So if you're having insomnia, having trouble sleeping, having stress, that could lead to extra cortisol production, which will increase your blood sugar. So yes, in some way, insomnia, lack of sleep, stress, can naturally increase. If you're sick, can naturally increase your blood sugar levels. But over time, once you're able to, kind of get things back down and settle down, your blood sugars could come down a little bit. But if you don't have diabetes, and your sugars are going, if you don't have diabetes, insomnia cannot cause you to have diabetes. But if you do have diabetes and your sugars are higher, insomnia could play a role there. But if you're having insomnia, that cannot lead your sugars to be excessively high that you end up having diabetes.
Yeah. So um it's better to get yourself checked to know. So I'm not sure,
Mhm.
like if you don't have diabetes, I guess you can do the test, but if you do have diabetes, is your diabetes controlled? That's
Mhm.
another thing. Because if it's your insulin, it's not controlled, then of course, it can also cause you to not be able to sleep at night too, and cause you to have depression
Mhm.
and stuff.
All right. So the GLP-1 receptor agonists, these have also been shown to reduce cardiovascular mortality and death. Okay, and the three on the market right now that have those studies are Victoza, which is a once-a-day injection, Trulicity, and Ozempic. So there's currently some data on also reducing kidney disease, and adverse effects are nausea, vomiting, diarrhea. Did we miss? I'm not sure if I was able to explain how they work. Is there a slide before this that we might have
Oh, let's see.
skipped?
Can
Yeah,
we
there
talk
we go.
about this? Oh, I guess
There we
after the question, I just moved on.
go.
Sorry.
There we go. It's okay. All right. So how do these medications work? Your GLP-1 agonists. So, like I said, these medications they're a hormone. They're not insulin, but they're also a hormone that your body doesn't produce as much of when you have diabetes. So these medications, it works in different parts of the body, and they work in four main ways. So the first way, it reduces excessive blood glucose production. So that's the second point there. It decreases inappropriate glucagon secretion. So if your body is producing, excess glucagon, which causes excess glucose, this medication helps suppress that. And the first bullet point right there, increasing glucose dependent insulin secretion. What that means is it tells your body to secrete insulin when your sugars are going high. Some other medications, which we'll go through later, tell your body to secrete insulin regardless. But this medication tells your body to secrete insulin when your sugars are going high, which is most likely after a meal. So it tells your body to release insulin when it should. So it reduces gastric emptying, which it reduces how much it slows down the speed your stomach is how fast your stomach is digesting food.
Mhm.
So when you eat, you might feel fuller for a longer amount of time. So it helps reduce hunger. So you might eat and you might not want to eat all day, and that's for some people with diabetes, that's a good thing. Also increases satiety, so reduces cravings, reduces you from snacking. It just makes you feel more satisfied and increases reduces your appetite a lot. So in general, it helps reduce your blood sugars after meals, which a lot of people struggle with. And this class of medications actually recently had an FDA approval for people who don't have diabetes but need weight loss. So there is a medication called Wegovy and one called Saxenda, and
Mhm.
they're pretty much the same thing as they have different names because of manufacturers. But They're actually approved for people who don't have diabetes but struggle with these with diet, at least to weight gain. So people who are obese and struggle with meals, they can be on these medicines for weight loss, who don't have diabetes, which again is good. Some of these medications that are coming out these days are not for diabetes only, so they could help regulate your homeostasis.
But why is it that most insurance, like you have a hard time getting it approved
Hmm.
for most patients?
So most times it comes down to cost, like because these drugs are expensive, right? So sometimes, insurance companies wouldn't want to pay for these drugs because they're expensive. But if you have proof that someone has tried and failed metformin, um, if you do the prior authorization, it would most likely go through because guidelines these days are not recommending. And I'm going to go over some of these drugs, but like the sulfonylureas anymore, the Actos anymore. So if a patient has insurance, and you do the prior authorization. But then again, it comes down to what insurance they have and what their copays are, because the insurance might approve it, but your copay is still two hundred
The
dollars.
copay is too high.
Um,
I think the hardest one is the ones for weight loss. Like
yes,
they
trying to use
don't
Wegovy.
want to approve.
Yeah, they don't want to approve, but they would want you to try. Now we're going off, but they might want you
Lifestyle.
to try like like some other agents, like Topiramate or Contrave or some of those before they go pay for like the expensive once weekly injectables, like Wegovy. So they might just have their step therapies that they follow, but I mean, what I always recommend, for some of because the thing is, if you have commercial insurance,
Mm-hmm.
from your job and your copays are expensive, there are a lot of coupons out there. If you just go on the website, a lot of times those coupons will take off $100 off your copays. Just So I personally, if you have commercial insurance from your job and you want to be on this medication, just go on the website. They have saving cards, they have coupons that will help take that cost down after your copays.
Okay.
Okay. All right. So we talked about this a little bit. So some of these medications have shown cardiovascular reduction, prevention. As far as side effects, because they work primarily in the stomach, they slow down the speed your stomach is digesting food. It can cause some nausea and vomiting. Okay, so if you eat a large meal, eat a really large meal, that food is gonna sit in your stomach for a long time and can cause nausea. So what I always recommend is eat smaller portions. You can eat 6 times a day if you like, but eat very small portions because if you eat a large meal, it's gonna sit there. You're gonna get nauseous. So just eat smaller portions throughout the day and listen to your body. If you're hungry, don't eat, because if you eat just because you haven't eaten breakfast yet and you're on these medications, you might get nauseous. So listen to your body. If you're not hungry, don't eat. If you're full, don't finish your plate. Just listen to your body, and that's why it helps with weight loss because it significantly reduces how much food you're eating. So some cautions, some cautions. There's something called gastroparesis, which is a state where your stomach is already not, moving like it should, and if you give these medications, it could worsen that, or a history of pancreatitis. Um, that second bullet point, I'm not going to go into that much detail here. It's they found that in rats, not in humans,
Mm-hmm.
that the medications at excessive doses can cause medullary thyroid carcinoma, but it hasn't been found in humans yet. But these are things that some patients might see on TV and say, "Oh my goodness," but it's only been shown in rats. It hasn't really been as far as I know. Like the medication has not caused any medullary thyroid carcinoma yet. And you also don't want to. You need to be careful with some people who are already on insulin on these medications because it does let your body use your own natural insulin like it should, and it could cause low blood sugars. Cash price very expensive. So you need to make sure you have at least insurance before you recommend your doctor to prescribe any of these medications for you. Or if you have $1,000 to
Uh,
spend.
I don't know. Every single month. That's
Right.
one.
So, so these are what some of these devices look like. When some people think about injections these days, it's you think about something else. But these medications, they've gone a long way with trying to make some devices very user friendly. The Trulicity on there, the let's see, 1, 2, 3, 4. The fifth device down is an auto injector, so you don't even see any needle. You don't have to do anything with any needles. You simply just put it on your stomach and you press a button, and it does the injection for you. So they try to make this as simple as possible for people to use. But these are what they look like for some people who've never seen this before. And again, just because they're injectables, again, some of these are once a week, but no, I always tell people they are not insulin. Some people confuse some of these injectables to be insulin. They are not insulin. They're once a week, and they have a lot of benefits. So please, if you're out there listening to this and your doctor recommends one of these medications for you, please jump on it. Just because of how much every year there's always some new data showing the benefit of these medications. And like I said, they're even used in people who don't have diabetes at all for weight loss and to help control meals. Okay, next slide, please. Okay, so I'm going to go over these briefly. So these medications are called dipeptidase 4 inhibitors, also called DPP4 inhibitors. So there's 4 on the market: Nacina, Tradjenta, Onglyza, Januvia. The reason why I have Tradjenta in bold is because Tradjenta does not need to be dose adjusted in renal impairment. So regardless of your kidney function, regardless of your liver function, Tradjenta is safe. So that's always my go-to for anyone who needs these medications.
I don't know how you guys say the names so fast.
Oh.
Like,
All right, so I'm going to give a brief explanation of how the DPP4 inhibitors work. So those GLP-1s that we talked about earlier, they're naturally produced in your body. The DPP4 enzyme breaks down your natural GLP-1. Okay? So what the scientists did is they found a way to stop that breakdown and allow your body to have its, to produce more of its own natural GLP-1. That is how this medication works. So that's why they are called a DPP4 inhibitor, because they inhibit that DPP4 enzyme that breaks down your natural GLP-1. So they work similarly to the GLP-1s, but they are not as effective. They don't have that slowing of your stomach emptying. They don't have that satiety portion. They don't cause as much weight loss, but they do help with they do help your body to use your own insulin better, especially after meals. So they work, just very little. So I only recommend this medication to some people who are very intolerant. You can't tolerate a lot of medicines. You have a lot of side effects. You're older, frail. That's when I might recommend these medications. You just need a little bit of A1C reduction. You don't want any side effects. You just want, to have a little bit of management. Then I could recommend these medications. But in general, they have not been shown to have cardiovascular mortality reduction. Yeah, so they don't reduce kidney disease and things like that. So they don't really have much benefit outside of diabetes. So that's the class DPP4 inhibitors. All right. So I already talked about this very low side effect profile, no cardiovascular data in the market, and they're still expensive. And there is no need to use a GLP-1 agonist and one of these medications. So it's either or, not both, because they work very similar.
okay.
Okay. So I always have a hard time saying also, so I'm just going to call them TZDs. So TZDs, all they do is they increase your insulin sensitivity. That's all it does. It changes your cells at a genetic level to use your own natural insulin better. So it takes a little bit of time for them to work. It takes about 6 to 8 weeks because they are changing your genetics to allow your body to be more sensitive to your insulin. So some people might start this medication and in a week they're like, my sugars haven't changed. I'm like, just give it time. It takes about 6 to 8 weeks for that to happen. The 2 on the market, you have pioglitazone, which is called Actos, and you have rosiglitazone because of Andia. And they have, if you see that the A1C reduction it varies because again, all it does is it makes your body sensitive to insulin. So if your body is not producing its own endogenous insulin, it's not going to work as well. If your body is still producing a lot of insulin, it's going to work well. So there is a variability with its effectiveness. Okay. So you don't want to use these medications in people that have heart failure. It could cause some weight gain and edema. You need to be cautious in renal impairments, but they're fairly affordable, between $20 to $100 a month, depending on your pharmacy. Cash price, but a lot of insurances do cover these. Okay, next slide, please. So sulfonylureas, these are some older medications. They've been around the market for a very long time. And these medications, all they do is they tell your body to secrete insulin. So they're called the three on the market is glyburide, glimepiride, and glipizide. The best way I explain this medication is if you think about it like a horse. Your pancreas is like a horse. When you first have diabetes, your pancreas is strong. You're releasing insulin. You give someone this medication, it releases insulin. It works. It works. It works. But the longer you're beating that pancreas, all of a sudden the pancreas is going to get tired and is not going to produce insulin anymore. So
Mm,
if you're not producing insulin anymore and you're taking this medication, it's almost like whipping a dead horse because nothing is going to happen.
mm,
So it's good in the early stages of diabetes, but if you've had diabetes for usually about 5 years or 10 years, these medications might not be effective anymore. So it's just something to think about if you're still on these medications for a very long time. But they work very well when you first, if you start them when you first have diabetes. But over time, that effectiveness goes down. So they are no longer recommended, according with they're no longer recommended by the American Diabetes Association just because, again, there is no proven cardiovascular benefit with these medications. But it could be used in the early stages, or if you don't have insurance, because they're fairly affordable medications. Next slide, please. All right, so I already talked about this. They're no longer recommended, especially glyburide, due to risk of hypoglycemia. And these medications, like I said, when you take them, it tells your body to secrete insulin, but there is no range. It doesn't tell your body to release insulin this much. It just tells your body to release insulin. So a lot of times, some people might have low blood sugars because they might be producing excessive insulin when they don't need it. So it could cause low blood sugars. So it's no longer recommended by the ADA, especially glyburide, because works for a long time. And you want to be careful in people who are over 65 with these medications because of risk of low blood sugars and risk of falls and things like that. Next slide, please. All right, so your meglitinides, they work just like the sulfonylureas by telling your body to secrete insulin, but the difference is this works very short. These medications work for like 2 or 3 hours. So primarily with meals. So you take it right before you eat. It tells your body to secrete insulin with your meals, and then after 3 hours or so, the medication has gone away. So
mm.
it's very rapid, and it helps reduce sugars from after meals because it works for just a little bit of time. Okay. So in general, if you're skipping a meal, you want to skip these medications because it could cause a low blood it could cause an unnecessary low blood sugar if you're not eating anything. And right now there's a Prandin, also called repaglinide, and Starless called Niclinide. But these you hardly ever see people on these medications.
Mhm.
Okay.
Mhm.
Yeah. All right. So we're done with most of we're done with the common diabetes medications. So a lot of these medications come in classes, or come in combinations. So you have combo pills. So I always recommend if you're on multiple medications, see if you can combine them, because if the insurance is paying for one, they most likely will pay for the combination. So just try to make your patient's life easier, or trying to make your life easier too by seeing if there's a way you can combine your tablets. All right, so I'm going to talk about insulin very briefly because a conversation about insulin could last again another hour. But in general, you have basal insulin, which is called your long-acting insulin. It works for 24 hours, and those are the insulins that are on the market: Levemir, Lantus, Basaglar, Toujeo, and Tresiba. I like Tresiba a lot personally because it lasts for 42 hours. That lasts a very long time. And then you have your bolus insulin, which are called your mealtime insulin. These work for about 3 hours. You inject right before you eat, and it helps reduce your blood sugar. So one is basal insulin, long acting, 24 hours. The other is bolus insulin or mealtime insulin. And those are the insulins on the market. And you have some mixed insulins, which are older. No one really uses them anymore. But most times right now it's just basal, long acting, and bolus mealtime.
Mhm.
And on the right hand side there, you have a medication called Soliqua and Zoltofi. What that is a combination of those GLP-1 agonists and insulin together. So if you
Mm.
have a patient who's on insulin and you're trying to start a GLP-1, they have combos for those two, so you don't have to inject twice. Okay. Okay. Next slide, please. All right. So as far as insulin dosing, so for type 2 diabetes, generally, you recommend starting at 10 units a day, or if you're dealing with a bigger individual, you can start weight based. I usually shoot for zero point 0.2 units per kilogram is usually my recommendation. But you can start at 10 units, and you want to slowly titrate up. So The long-acting insulin, the way to know it's working is based off your fasting blood sugar. So that first thing in the morning blood sugar. And that blood sugar goal is between 80 and 130. So if you inject your insulin at night, you wake up in the morning, first thing in the morning, you test your sugar, and your sugar is still above 130, and you have not eaten food for about 8 hours, it might be
Mm.
time you need to up your insulin dose. So if you feel comfortable, people could self-titrate their insulin by 2 units every 3 days until they get to that goal of 80 to 130 in the morning. Um, so if you're on long once a day basal insulin and you A1C is not our goal, it might be time to also add a mealtime insulin. And mealtime insulins are usually started at 4 units or 10% of your basal dose, and that could also be slowly titrated. For type 1 diabetes, you usually start at zero point 0.5 units per kilogram per day, and then you split that dose by two, 50% to be your basal once a day, and then the other 50 you divide by 3 per meal. So that's the insulin initiation for type 1 and type 2 diabetes. Next slide, please. So some general pearls. Um, you want to consider adding one of those GLP-1 agonists before you add on insulin. Um, if you're on insulin and you're starting to get to greater than 0.5 units per kilogram, it might be time to add a GLP-1 agonist or a mealtime insulin. We don't want to just keep increasing the insulin. It might be time for you to add some other agents. When you start insulin, consider stopping one of those sulfonylureas because it's doing the same thing. You need to test your blood sugars if you're on insulin. There's no way for you to know how well your insulin is working if you're not testing your blood sugar. So please, if you're on insulin and you're not testing your blood sugars, start testing your blood sugars because that's the only way to know how things are working. And insulin costs vary between $100 to $500 depending on, and there's some cheaper insulins over the counter also. So this slide right here, this is pretty much recommended for our medical providers. Because now guidelines are recommending medications based off of disease states. Right? So if you had a history of cardiovascular disease, if you have a history of kidney failure, if you have this, it breaks down, when to use what medication. It also breaks down by cost. If cost is an issue, try this or this. So I like this slide a lot just because, I recommend, most of our providers have this hanging on a wall or something in your office. And there's another slide that this is by the ADA, but there's another slide I don't have it here, but another little chart by the American Academy of Clinical Endocrinologists, the AACE guidelines, that it's also beautiful and very easy to follow. So I just wanted to have this on here. It's a general recommendation for our medical providers.
Awesome.
All right, so some general pearls. So if your A1C is above 1.5 on diagnosis, you might need to start 2 medications just because some of these medications work in different parts of the body. So insulin, you might need to start insulin early if you're having signs of unintended weight loss and signs of high blood sugar. So like I said before, if you're having weight loss unintended, it might be a sign that your body is not producing insulin anymore. So if you're having, you're peeing a lot, increased hunger, increased thirst, and your sugars are really high, it might be time for you to start insulin to save your life. If your sugars are really high. And again, if you have a history of cardiovascular disease, please, you need to be on medications or you need to recommend medications that have shown to reduce cardiovascular mortality.
Do you have any tips on like what to tell patients? It's like, especially like the male patients.
Mm-hmm.
So for example, if let's say patient's A1C is 14, greater than 14%,
Mm-hmm.
and they're saying, "Oh, I don't want to do no insulin,"
Mm-hmm.
and like they're really serious, very
Mm-hmm.
resistant to starting insulin.
Yeah. I mean, I just usually I would explain the risks, to them. And and I always tell patients too that just because we start insulin now does not mean you're gonna
You're
be on
gonna
it
be on
lifelong.
it, yeah.
I'm like, let's start it right now. Let's get your A1C down. Let's get it a little bit. Let's get it less than 10. And I'm pretty sure, and it's usually easier to get A1Cs down from 14 to like 9 very quickly, as compared to when you get to the 8s or the 7s. So it's like, hey, let's start it at least, let's do it just once a day, start basal, just once a day. for for a month, and let's see what happens. And then if they're and just usually when I let them know that let's just use it for right now until things get a little better, then we can stop and put you on some of these other meds. I mean, it doesn't happen every time, but sometimes we're like, okay, I'll try it. you know
Mhm.
um and yeah, that's usually what I tell them is it's not lifelong, it's not long term. Let's get you safe, and then we can start trying different things.
Can you go straight to something like Trulicity
You
instead?
can, you can, um you can. It might not, I mean, if a it can help reduce the the A1C a little bit, but I doubt if you're at 14 and you start Trulicity, especially if you're showing signs of insulin deficiency, right? If you're having the unintended weight loss, you're having signs of hyperglycemia, and you start Trulicity, you know, it might help, but I don't know how much. I doubt it to get them down to goal. But if
Mm.
they're not, if the A1Cs are above 14, and they're not having signs of insulin deficiency, they're not losing weight, they might be having some hyperglycemic symptoms, but if they're still gaining weight and you start Trulicity, it could help. They could drop down significantly because they're still producing endogenous insulin, and the Trulicity would do its thing and get them down. But it all depends on where they are in that stage. So you could order a C-peptide, and that could also help determine your course of action. Are they producing endogenous insulin, or are they not? If they're not, then you know they need to be on insulin. But if their C-peptide levels are not low and your A1C is 14, then you can absolutely just start with other meds and not insulin.
Awesome.
All right. So some general pros, like we have a question in the chart. If cost is not a problem and A1C is about 8, what is your favorite go-to? So if this is new diagnosis, my favorite go-to is Synjardy, which is the
Mm.
combination of metformin plus Jardiance. That's my go-to, and I usually recommend starting at 505 once a day for the first week, and then bump that up to BID, so twice a day. And then when I check with them again, if they're doing okay, then I bump them up to 1,012.5 twice a day after that. And but if they're about 8 on diagnosis, I like Synjardy or Invocamet. And that's a combination of metformin and Invokana, just because they to the patient, they don't know they're, I mean, you're taking two medications in one, but it's still just one tablet, so it doesn't really seem like, gosh, I
Yeah.
need too many medicines. But they're already starting dual therapy there, but it's just one tablet a day, so you're just, yeah, knocking out two birds with one stone. All right, so some general pearls. If someone is on insulin and they're still on like a glipizide glyburide, just stop it. It's just a waste of money, waste of a tablet. um, if like I said earlier, if patients are having a metformin for a long time and is trying to have some neuropathy or anemia, check B12 level first before you start treating the neuropathy with gabapentin or pregabalin, or treating the anemia with iron. Just because if it's the B12 level, all you need to do is replace B12, and not have to reduce polypharmacy, adding on extra meds. Um, every patient over the age of 40 who has diabetes should be on a statin. I always say this to all our medical providers. If they're over the age of 40 and they have diabetes, they should be on a statin.
So
That's a conversation for a different. Huh, sir?
we get those things from you guys.
Yeah. I always sing it like a song. I'm like, Where's their statin?" It's, if you're over 40. Um, you know, consider aspirin. In the past, it was always a recommendation to be on aspirin if you're over the age of 50, but now guidelines have changed because of the risk of bleed. So you need to assess the patient. If they're over the age of 50 and they have cardiovascular risk factors, they have diabetes, plus they have hypertension, plus they're a smoker, then maybe they might need to be on aspirin, but not everyone over the age of 50 needs to be on aspirin when they have diabetes. That's like before. Consider ACE and ARBs. So ACE and ARBs, medications like lisinopril, losartan, and those should be recommended in patients that are starting to have sign of kidney disease. So you have that albumin creatinine ratio of greater than 30, is early sign of kidney disease. So consider ACE and ARBs. If a patient is on an SGLT2 inhibitor and they start having genital yeast infections, just don't stop it. Okay, I always recommend give them the fluconazole 150, one treatment, and reassess. Just don't stop it. these medications have a lot of benefit that we just don't want to stop it because they had one incidence of a yeast infection. I would say re-challenge. If they have multiple, like two or three, then maybe you need to stop. But just reassess. How is their hygiene? Are they well hydrated and things like that, and use combination pills if possible. All right. So again, some pros. When in doubt, order antibody testing. It's happened multiple times where we have patients on metformin, SGLT2 inhibitors, GLP-1, and nothing is happening. Then I would just recommend let's order those antibodies, let's order a C-peptide, and then boom, all of a sudden they have what's called either type 1 or what's called LADA, which is latent autoimmune diabetes of the adult. Whereas like a late onset antibody destruction. So when in doubt, if you're trying all these things and the patient swears, I'm taking all my medicines but nothing is happening, just order it, just to rule out antibody destruction. Okay, next slide please. All right. So prevention of type 2 diabetes, lifestyle modification. Most generally recommended is 150 minutes a week of low to moderate to vigorous activity. It doesn't have to be intense. You don't have to go running. Just walking outside, wherever. 30 minutes, 5 days a week is sufficient to improve that insulin sensitivity, and reduce your risk of going towards type 2 diabetes. And metformin could be started early on, even if they just have pre-diabetes.
And you don't have to go register in a gym. That's one of the another common thing. Oh, but I don't have money to go register in the gym. Like you don't need that.
Yeah, just general walking is fine.
Yeah.
Okay, that's all I have. I'm sorry I went over. Like I said, when it
No,
comes
no.
to
You're fine. Thank you so much. I think that was very like really impactful. I learned a lot, and I'm definitely listening to this again because there are some tips there that I can use for some people to help people out, and then even with my patients, because of course you meet some that are a little bit resistant, and there are a lot of pearls there that I can definitely use. And can we share this slide? Like if someone were to ask me for this slide, am I able to give it to them?
yeah, sure, that's fine.
Okay. All right.
Yeah.
I mean, it still have your name and everything,
I
but
mean, it doesn't. I mean, it doesn't matter. I it's whatever you want to
oh,
do with it. You can. You could take
yeah.
my name off. I
No,
don't.
no, no, no. We want your name there.
Just for just
Yeah,
for this
most people
discussion.
will ask later, can I have the slides? So I just want to make sure that I get that. Go ahead to share the slide. So does anyone have any question? If you do have any question, please post it so that we can. If not, then we can just round up. Before we do, thank you so much, Neto, for this. This was really, really awesome. I can tell that you love what you do. So yeah, and we do get those recommendations from pharmacy all the time. Hey, and by the way, most of them are wrong. You say, oh, this patient is not on a statin, and you take the time to go search, and yes, they
Dude,
are.
I know, I know.
So, but I think if nobody has a question, I just want to say thank you so much.
Mhm.
Oh, and then one more thing. If someone wanted to like get in contact with you or something, am I allowed to like connect
Please,
them?
please, absolutely. Yeah, you can share my email, my number. That's fine. Yeah, no, thank you. Like I said, I could talk about diabetes for hours. So it definitely, to me, it's a joy. So thank you for the opportunity and the privilege to talk about something I really like. And so thank you.
All right. So thank you, everyone. I think we are done at this point. If you Oh, yeah, someone said thank you. Yes, thank you, thank you. If anyone has any question later, you can always ask. But thank you so much, everyone, for joining. It was an awesome time. Thank you, Nido. Have a
Thank you.
blessed day.
You too. Thank you.
All right. Okay. All right, guys. we are going to end it since nobody has any question. It was an awesome time. Thank you for coming. All right, bye.